What if your doctor sat you down tomorrow and told you that you needed surgery and you just said yes without asking a single question? Most people over 60 do exactly that. They trust the recommendation. They sign the papers, they go under the knife, and nobody tells them the truth beforehand that some of the most commonly recommended surgeries in America carry risks after age 60 that most patients never hear about until it is too late. Today, I am going to share 5 surgeries that many doctors and medical experts now say should be questioned, reconsidered, or outright avoided if you are over 60. And I promise you, at least 2 of these will genuinely surprise you because they are procedures that millions of seniors accept every single year without hesitation. Stay with me all the way through because number 4 is the one that shocks people the most. Hello, I am Dr. Harrison. I have spent decades in internal medicine working with older adults, and I have seen firsthand how surgery affects the aging body very differently than it affects someone in their 30s or 40s. After 60, your body's ability to handle anesthesia, recover from trauma, manage post-surgical infection, and rebuild tissue changes significantly. That does not mean all surgery is bad. But it does mean that some procedures that sound routine are far more complicated and risky for seniors than the brochure ever mentions. And today, we are having the honest conversation your doctor may not have time or, frankly, the courage to have with you. Let us get into it. Before we name the 5 surgeries, you need to understand something important that most people do not realize until they are recovering in a hospital bed. After the age of 60, your body processes anesthesia more slowly. Your kidneys and liver, the organs responsible for clearing those powerful drugs, work at a reduced capacity. That means anesthesia lingers longer in your system and can cause something called post-operative cognitive dysfunction. That is a medical term for a condition where older patients wake up confused, forgetful, and in some cases, never quite return to the mental sharpness they had before surgery. Studies suggest this happens in a significant portion of patients over 65, and many families describe it as their loved one never being quite the same after an operation. On top of that, healing is slower. Blood clots are more likely. Infection risk is higher, and the emotional and physical stress of surgery can trigger heart complications that were never on anyone's radar before the procedure began. Now here is what I want you to remember as we go through this list. I am not saying refuse all medical care. I am saying ask better questions, get a second opinion, understand your options, because in many of these 5 cases, there are alternatives that work just as well or better without the operating table. Surgery number 1 is spinal fusion for back pain. Raise your hand if your back hurts. If you are over 60 in America, there is a very good chance you have been told at some point that spinal fusion surgery might help your pain. Here is what the research actually shows. Multiple large-scale studies, including work published in respected medical journals, have found that for most types of chronic lower back pain in older adults, spinal fusion surgery produces outcomes that are no better than physical therapy, targeted exercise, and pain management. And that is not even the concerning part. The concerning part is the recovery. Spinal fusion is a major operation. It requires significant anesthesia time, a long hospital stay, and a recovery period that can stretch into months. During that time, seniors are at risk for blood clots, infection, and dangerous immobility. And in many cases, the pain returns sometimes worse within a few years, leading to a second surgery. Before you agree to spinal fusion, ask your doctor directly whether you have fully exhausted non-surgical options, because the research suggests you should try them first. Surgery number 2 is knee replacement when it is done too early. Now, I want to be clear here. Knee replacement surgery has genuinely helped millions of people live better lives. When it is the right option at the right time for the right patient, it can be life-changing. But here is where it gets complicated. Many seniors are being recommended knee replacement surgery earlier than necessary sometimes when the arthritis is moderate, not severe. And when surgery happens before it is truly needed, the artificial joint has a lifespan. Most knee implants last between 15 and 20 years. If you have surgery at 62, you may very well need a second replacement surgery in your late 70s or 80s when your body is even less equipped to handle it. A second knee replacement, called a revision surgery, is significantly more difficult, more painful, and carries far higher complication rates than the original. So, if you have been told you need a knee replacement and you are in your early 60s, ask this question. Am I at the point where surgery is truly necessary right now, or can I manage effectively for another several years with physical therapy, injections, and lifestyle changes? The answer may surprise you. Surgery number 3 is cardiac stenting for stable heart disease. Stay with me on this one because it matters deeply and it surprises nearly everyone. If you have been diagnosed with stable coronary artery disease, meaning your arteries have some blockage, but you have not had a heart attack, your doctor may recommend placing a stent. A stent is a small metal tube inserted into the artery to open it up and improve blood flow. For decades, this was considered standard treatment. And then a landmark study came out that changed the conversation entirely. The ischemia trial, one of the largest cardiovascular studies in recent history, found that for patients with stable heart disease, stenting did not reduce the risk of heart attack or death compared to medication and lifestyle changes alone. Yet stenting procedures remain one of the most commonly performed cardiac interventions in older Americans. Many patients are never told that medication and supervised lifestyle changes may carry the same long-term outcomes with far less risk. If your doctor recommends a stent and your condition is stable, please ask whether you are a candidate for medical management first. Surgery number 4 is carotid endarterectomy in low-risk patients. This is the one I told you about earlier. This is the one that tends to shock people most. The carotid arteries run along both sides of your neck and supply blood to your brain. When plaque builds up in those arteries, a condition called carotid stenosis, there is a risk of stroke. And carotid endarterectomy is a surgery that physically clears out that blockage. For patients who have already had a stroke or a mini stroke and have severe blockage, this surgery has strong evidence behind it. It saves lives in those cases, but here is where things get complicated for seniors. For patients with moderate blockage who have never had a stroke, a growing body of evidence suggests that modern medication, including statins and blood thinners, may be just as effective at preventing stroke as surgery. And for older patients, the surgery itself carries a meaningful risk of causing the very stroke it is meant to prevent. The procedure involves working directly on the arteries that supply your brain. The risk window around the surgery, particularly in patients over 70, includes stroke, heart attack, and nerve damage. If you have been told you have carotid stenosis and surgery has been recommended and you have not had a stroke, please get a second neurological opinion before proceeding. This is a case where the conversation about risk versus benefit is absolutely critical. Surgery number 5 is unnecessary gallbladder removal. This last one might be the most common on this list and the most misunderstood. Gallstones are incredibly common after 60. Studies suggest that a large percentage of Americans over 60 have gallstones, and here is the important part: most of them never cause a single symptom. They just sit there quietly, doing nothing for years. The problem is that when gallstones show up on an ultrasound or a scan, even by accident, even during testing for something else, surgery is often recommended preventively. Gallbladder removal, called cholecystectomy, has become one of the most frequently performed surgeries in the United States. And while it is considered a routine laparoscopic procedure, routine does not mean risk-free for a 68-year-old. Research has shown that for seniors with gallstones that cause no pain, no nausea, and no symptoms at all, the risk of actually developing serious problems is quite low. And the risk of surgical complications in older adults is measurably higher than in younger patients. If you have been told you have gallstones and surgery has been recommended, ask your doctor clearly whether your gallstones are actually causing symptoms or whether this is precautionary. Because watchful waiting is a legitimate evidence-based option in many cases. Now, let me give you 5 questions that you should ask before agreeing to any elective surgery after 60. First, ask what happens if you do not have this surgery right now. Second, ask what the non-surgical alternatives are and how their outcomes compare. Third, ask what the specific risks are for someone your age under anesthesia. Fourth, ask whether this surgery is addressing your symptoms or just a finding on a test. Fifth, ask whether you can get a second opinion before making this decision. A good doctor will welcome every single one of those questions. And if a doctor makes you feel rushed, dismissed, or pressured, that is your signal to seek another opinion before you do anything. Here is the bottom line. Surgery is a powerful tool. It saves lives every single day. But it is not a decision that should ever be made quickly, without full information or under pressure. After 60, your body deserves extra care and extra caution. The 5 surgeries we talked about today are spinal fusion for back pain, premature knee replacement, cardiac stenting for stable disease, carotid endarterectomy in low-risk patients, and unnecessary gallbladder removal. These are all procedures where the evidence increasingly supports asking hard questions before saying yes. You are your own best advocate. Ask the questions. Request the second opinion. Give yourself time to decide. And if this information helped you today, please share this video with someone you care about, because this is exactly the kind of conversation that could protect someone's life. Leave me a comment below and tell me whether a doctor has ever recommended one of these surgeries to you or someone in your family. I would love to hear your experience. If you found this valuable, click subscribe and hit that notification bell, because every week we bring you honest, straightforward health information designed specifically for people over 60 who deserve real answers. I am Dr. Harrison. Take care of yourself, and I will see you in the next one.